Good evening, ladies and gentlemen. Thank you for inviting me to talk on redefining treatment in multiple myeloma, mostly based on ASH 2021 meeting. This is in next 20 minutes. Actually, I will take you a few steps, introductory of multiple myeloma, how I treat multiple myeloma, challenges and solution. Then we'll go to ASH update. Should we use our best treatment first or save for later? Based on the ASH, we'll do for Caspia part 1 and 2, and then MIA and acyclone. And based on the ASH 2021, we see how the treatment sequence should be. And my final question will be with you as per ASH 2021, how to implement trial, how do you predict multiple myeloma in 2022? So which guideline we use treatment for multiple myeloma? Everybody use 4 guideline, but we use NCCN guideline. So what NCCN guidelines say about transplant ineligible patient? So these are options. Preferred option is RVD or DARA-RD based chemotherapy. So now second part is how we treat actually multiple myeloma. We treat by, A to G hits. A means accurate diagnosis staging. B, before beginning treatment, check the proper indication and target. Choose wisely with the optimum drug. Efficacy by MRD, if not feasible, check by the total immunoglobulin and clinical parameters and use guideline and then how I treat. So first is accurate diagnosis. First case, 67-year male who came to us in 2021 with 3-week history of backache, with the background of hypertension, and he has lytic lesion on X-ray, and he has pain 7 out of 10. And here you can see IgG was high, and it was about 9, and serum electrophoresis revealed the IgA kappa is 4 grams. The important thing is you notice with the high all risk parameters, beta-2 macroglobin, LDH, and albumin, and the cytogenetics also revealed high risk. So the diagnosis is IgA kappa, multiple myeloma stage 3, high risk. Now, if you go by before starting treatment, yes, he has all indication of treatment, slim and grab. So he has active IgA kappa multiple myeloma. So yes, treatment needed. So now choose wisely with optimum drug. So patient is high risk. And as we know, multiple myeloma is 2 types. One is like this type, which is high risk multiple myeloma, which is ALL type, other is follicle type of myeloma. So it's high risk multiple myeloma patient. So now, again, choose wisely. Discussion of the patient. The patient has high risk, good performance status. The patient is eligible for transplant. So D for drug, optimum drug and first line. So you have plenty of options. So what even NCCN say best is the 3 for these patient, but we use here VRD based chemotherapy. So if you are confused, go to expert online to decide whether what they use, triplet or quadruplet. They are also 50-50 divided. Some says RVD, some say DARA plus RVD. So somehow this patient took radiotherapy as he has severe backache, and then we started VRD-based chemotherapy, which is SWOG S0777. You can say after 3 cycles during chemotherapy, the disease progress, so we can call this patient as a refractory to VRD. And you can also appreciate, compare with the previous MRI, there was new compression fracture and new lesions over there. So he has clinical and biochemical disease progress. So refractory disease, the next option is DARA triplet. So he was given DARA triplet. Now he's going for autologous transplant. So I wish first time we should give DARA RVD, but we were late. Similarly, second case, 62-year female who has history of backache. She went vertebroplasty in March 2021. Lesions were compatible with a myeloma, and we diagnosed finally stage 3 multiple myeloma high risk category. Again, similar patient, you can say VRD-based chemotherapy was given, transplant eligible patient, but after 3 cycle disease progress. So finally we give DARA-based chemotherapy. Now disease remission, she's going for autologous transplant. So what we learn lesson, from these two cases, they built up our challenge one, that patient with high risk have poor outcome, please take care of it. So there is option. Multiple myeloma is not one disease. It goes from green to red color disease. So my patient was actually red color disease, high risk disease. So this patient may need quadruplet rather than triplet. So challenge two is, we know, multiple myeloma gets harder to treat with each relapse. We will show also later. Treating multiple myeloma is marathon, it's not a sprint. So you have to choose wisely. If you choose wisely as a first go, early intervention, it gives benefit to go through other relapse. Johnson has committed to give Velcade first time. They redefined the multiple myeloma, but despite of this, you can say still the disease relapse. So now there is solution. We have now monoclonal antibody daratumumab that promotes the myeloma cell death through the direct on-tumor activation cell and also immunomodulator action. Now, treatment paradigm is there: induction, three triplet, quadruplet, autologous, yes, timing, consolidation, which consolidation, maintenance. So where there is a village, there is way. We learn a lesson. During induction, we have to make it which patient needs triplet or quadruplet, and which patient needs delayed or upfront transplant, then consolidation, and then maintenance. Now, fifth question is actually what we presented in ASH 2021 this year. Is the patient newly diagnosed myeloma not eligible for transplant? Should we use our best treatment first, like DARA-RD, or we save for later? So actually, this was abstract presented in this meeting. Actually, they explored three potential clinical benefit sequence based on the published data, DARA-RD, VRD, and RD base, and they found the attraction rate that what if you use as a second line and first line first. So their attrition rates in Maya base was 58, and then they use other conservative Maya base, which is 27% attrition rate. Attrition rate means when first line is failed, how to go second time you go in second line treatment. So what they have shown, the people who have survival 58% attrition rate, here you can see the yellow is the RD, and the blue is the VRD, and green is the DARA-RD. So you can appreciate over the 5 years, it is almost 20% higher. And even after 10, you can say it is 41% higher. So similarly, even you use conservative also, it is also 20% give benefit by adding the DARA. So you can say the attrition rate has given benefit, even if this is general population survival. So it is almost, you can say it's 20% less than the general population. Now, additional DARA can give 2 years benefit. If you see here, it is RD is 4.1 and 5.1, and then his 7.6. So it means additional DARA give 2 years benefit. Even in the other attrition rate, it is also 9.1 years. So now in this abstract, we have seen, we commonly use medication today, but we don't receive, the attrition rates can't count the patient who don't receive treatment beyond the initial first line, and they also use real world data inputs for second line as well. So this is the strength. But the limitations for there, the patients who are not lost to follow up, they were also included, and there was mix of the data sources. So this was the limitation. So however, they concluded in this abstract that DARA, RD, and VRD are commonly used treatment for transplant eligible patients based on the Maya and SAVOG S0 777. They have shown benefit, but not more than 65 years of age, only younger patient. Our study suggests that DRD first followed by POMA containing regimen provides 2.5-year overall survival benefit. So given the totality of the data, DARA-RD should be demonstrated treatment option with the treatment with the transplant eligible patient as a first line therapy. Now, this was the first abstract. Second, again, interesting abstract in ASH 2021 in transplant eligible patient. Actually, this was Cassiopeia part 1 and part 2 update. We know Cassiopea part 1, they actually update DARA, VTT, induction and consolidation. And in part 2, actually, they presented DARA maintenance for up to year follow-up. But now what they presented here, because we know MRD is associated with the PFS and emerging valuable prognostic marker. So what they use here they present an MRD result from Cassiopea to demonstrate the impact of the DARA maintenance on the MRD negativity. So in first part, they use bone marrow samples were collected for MRD. In part 2, actually, they analyze using NGS. So this was the treatment plan in this Cassiopea. Just to remind you, they use standard VTT, and here just they did DARA, induction, consolidation, and in maintenance, and here is the observation. Now we'll see the result. We have seen the first update that CR was rate included DARA, VTT was higher, and MRD negativity was also seen higher here as well. Now, actually, this time they are, we're more focusing on the maintenance. What is the update? So in maintenance update, you can say they maintained actually. Here you can say it's about 20% increase who continue DARA as a maintenance. Now this is more clear picture which shows this is the best one, DARA VTT followed by DARA maintenance. You can see it's about 64% response, and the green one, this is the CR57 is this one. So 10 minus 5 to 10 minus 6. And again, DARA VTT observation is 58%. It means DARA is given benefit to all, and the people who have taken just VTT first, then the DARA was included, they also got benefit, 53% they got. But the people who have never used DARA, this is the response. So there is clear-cut benefit, and aesthetically shown also benefit as well. Here is the overall response is 0.00 to 10%. Now, what we conclude in here, MRD negativity and sustained MRD negativity rates were significantly higher after DARA VTT induction and consolidation versus VTT. DARA maintenance show improved MRD negativity in the VTT treated patient compared with the observation. DARA VTT followed by DARA maintenance is highest MRD negativity and sustained MRD negativity rate. Longer follow-up is needed to adequately assess the PFS and overall survival. Ongoing studies, just Griffin, Perseus, and Aregia, we shed more light on optimal maintenance strategy using DARA plus lenalidomide. Now, what else was presented as 2021, especially in transplant ineligible patient? We are aware transplant eligible, two big trial, S-Cyclone trial and MEA trial, which is more than 700 patients. They were actually, we know very well, they have shown overall 15 to 20% higher overall response rate and the survival. What they show, this we know the guideline, if eligibility of transplant is not there, they put, that's why DARA RD or DARA VMP or VRD, as a first line for the non-transplant patient. Now we'll go to ASH about this, what they have shown here this time. So this is again, just to remind you, this is more than 700 patient randomized trial, and they have shown 44% of patients in the MEA study were at least 75-year-old. This is very important. They are very old patients. It's not like other one, there was 65-year younger patients. So what they've shown, PFS shown 47% reduction in the risk disease progress or death because the hazard ratio was 0.53. And then again, the overall survival hazard ratio is 0.68. So what they indicate that 32% reduction in the risk of the death. And again, the PFS benefit, even elderly patients, this is most important thing which I mentioned, more than 75 years of the age, they have shown also hazard ratio is 0.63. It means 37% reduction in older patient as well. Of course, deeper response, you can see mark here, they have given, and even more than three times more patient with the MRD negativity versus RD alone primary update analysis. And then deep response at 6 months and 12 months, 4 times higher MRD negativity at 6 months and 12 months. So you can say this is about 6 months and this is 1 year, 12 months they have shown. And then longer time to progress or the death was seen in this trial. And intent to treat population was also shown that 35% reduction in the risk of progress or death on the subsequent line of the therapy. So longer median time to next therapy, more PFS, and especially more in elder patients. They have shown safety profile. There is no other thing was noted as before. Quality of life is already proved that meaningful improvement of the quality of life was seen with the DARA RD, and the treatment protocol is same. Everybody know, once weekly for 4 weeks, then 2 weekly, for again 3 to cycle 3 to 6, then every 4 weeks DARA until disease progress. So what else present in ASH 2021? The another is transplant ineligible patient. This abstract shows that first line uses of DARA confirms the survival benefit compared to the second line of DARA. Let's see. We know RD versus VRD. This is the benefit was seen, but this benefit was seen when the patients are younger, less than 65 years age. And older patient, they have not shown any benefit with the, this one. So our S0777, they have not shown. But the good thing is DARA RD is it younger and older patient, both transplant eligible patient, you have seen the PFS and overall survival. You can say hazard ratio is 0.53, is almost double benefit, and also here overall survival also translated. So this is a given benefit. So attrition rate, more than 50% patients receive only first line therapy. This is also high. So it is very important to choose the first line therapy very smartly. Then, because if you go further, the response rate will decrease. You can say 43%, 23%. So it's very important you have to use. Now, summary of ASH 2021. This is very good abstract. Actually, it was sum up all the multiple myeloma patients, improving outcome for patients with the multiple myeloma through the optimization of the treatment sequence. We know multiple myeloma is an incurable disease, and patient typically receive combination of the drugs, and patient go for autologous transplant. However, patient relapse, and we have seen the Cassiopeia trial, Maya trial, Acyclovir, and I have shown, demonstrated that adding DARA to standard of care in the frontline setting improves the patient outcome. Based on these data, European market for daratumumab has been extended first line setting as well to ensure the benefit. So this is the summary of the transplant eligible setting. Here you can say they made a benchmark. Benchmark is 12.7 year. Here you can say green color, which is divided very nicely, very clearly mentioned DARA based. They have shown 14.6. The highest was seen, you can say DARA based, then KRD based, and then other treatments. So they have shown in transplant eligible patients the highest, and then transplant ineligible patient, again the benchmark was 8.9, and what this blue color is DARA based chemotherapy. This is 11.7, which was highest, 11.2. Rest is 8.9, and so the rest is less than even benchmark, but the DARA based has given more than the benchmark. So what they conclude we believe that this is the first sequence simulation to consider optimal patient outcome, access serial line of multiple myeloma treatment. The results showed the longest time in remission achieved with the use of DARA-based regimen as a first-line treatment. They significantly improve the patient outcome. Time spent progress-free decrease with each subsequent line of therapy. Therefore, patients should be treated with the most effective treatment upfront. So the last 20 minutes, I have gone through the eye opener, then how I treated, and I have gone through all update from the ASH and the summary of the ASH. My last closing question is from you as per ASH 2021. How to implement this trial and how do you predict based on the DARA regimen in 2022? Thank you very much. I am here happy to answer you any question. Thank you.